Welcome, everyone. Glad that you're here today. It's my pleasure to introduce you to Dr. Micky Tripathi. Dr. Tripathi has had, an exciting career. He first met people from Regenstrief way back in the day, back in 2004 or 5, when he was the first CEO of the Indiana Health Information Exchange. So he has a very close previous connection with the Institute. After that, he continued doing work in data sharing exchange. He was the leader of the Massachusetts eHealth Collaborative. And then, of course, following that, that led to his work and leadership as the director of the Office of the National Coordinator for Health Information Technology. So without further ado, Micky, take it away.
Great. Thanks so much, Sean, and thanks everyone for being here. Really delighted to be here. Is the sound on this okay? Feels like okay. Really delighted to be here. It's been a while actually since I've been back. The airport is a lot nicer than I remember. I did, as Sean said, I was a consultant at the time with the Boston Consulting Group, working on a project with then BioCrossroads. To try to think about what would be a model for taking all of the great work that Regenstrief was doing and trying to figure out how to commercialize that. So that so you could expand the footprint of it and have it be have further reach in terms of not being just about research, but being things that could actually affect the healthcare delivery system. And IHI is the poster child for success in the health information exchange market. That John Kansky and the entire team took that and ran with it, and it's just it's fantastic to watch and fantastic to to help. Back then, it's kind of interesting. When I first came with a team from BCG, I was with the Boston Consulting Group. It was always awkward because there was the big Patriots Colts thing, and coming in the middle. And I was with the Boston Consulting Group, and I'm from Boston. I still live in Boston, and so that was always awkward. Time has passed. Now we have Celtics Pacers. Oops, sorry. That felt like it was closer than 4-0, didn't it? I mean, that felt like it was a really tight series. That did not feel like. But anyway. I also had the experience. This was where I got introduced to health IT and got the bug. I came here, didn't really know that much about health IT, and had to learn from the high voltage wire, which was Clem McDonald. And you can imagine what that was like coming in. For those of you who know Clem, coming in as a naive consultant, trying to sort of figure out the landscape, learning from one of the legendary geniuses in the field, which in hindsight was just the privilege of a lifetime. To be able to learn from Clem and Mark and and the entire team here at Regenstrief. So really delighted to be back here, and really delighted to see how much Regenstrief is thriving and contributing to everything we're doing at the national level. So I have about 233 slides to cover in 45 minutes. Now I do have a bunch of slides. In part, the challenge was with, and I think it's been a while, actually. I was thinking as I was putting the slides together, I was thinking it's been a while since I've had the opportunity to be with an audience that has such breadth and such depth. Most places that I speak, there's, sort of maybe organizations aren't that the audience isn't as sophisticated, and so they want breadth, but they're not that sophisticated in terms of any one of these areas, or they're very sophisticated in one particular slice, but not across the board. And as I was thinking about, well, this is going to be a Regenstrief, IHI, and clinical audience from from Indianapolis, it's like, oh man, they're like deep and broad. They know everything about everything. So how do I touch on all of that in 45 minutes? So basically, the message is, fasten your seatbelts. We're going to go through a whole bunch of stuff. The goal here was to give you a perspective on all the different things that we're working on, that hopefully in the in the Q&A, I'm happy to dive down into anything that that's of interest to any of you, and really go deeper. So just make sure I know where to point to. There we go. Oh. Okay, so ONC, the Office of the National Coordinator. I am the National Coordinator for Health IT. ONC was established in 2004 under then President Bush by executive order. coming out of, a lot of the work that was starting to go on across the country, and certainly Indianapolis was one of the leading places that was starting to inform, that there are ways of using health information technology to move all the healthcare delivery system forward, to be able to better serve patients at the end of the day through the better sharing of information and the better use of information technology in healthcare delivery. So that, sort of was the founding of ONC. We are a staff division in the Department of Health and Human Services, which means that I report directly to Secretary Becerra and Deputy Secretary Palm. And technically, as a staff division, I'm in the office of the secretary, along with the Office of Policy and Public Affairs, and the General Counsel's office, and a number of those organizations. And then we are like organization peers to the operating divisions, which are the ones you are more familiar with, probably FDA, NIH, CMS, CDC. Those are called the operating divisions. But all of us report directly up to the secretary. And as a staff division, one of the great benefits of being a staff division is that my job is to work across all of those operating divisions in our particular area, which is health information technology and policies related to that. So we work with CDC, CMS, every single one of the operating divisions on their health IT needs, which is, really daunting, but it's a real privilege as well, because you get to work on all these different use cases on trying to figure out what's important to them and how do you help them make it better. So we work across the federal government with all the federal agencies, as well as outside the Department of Health and Human Services like VA, DOD, as well as with the market, trying to move the market toward a better, sort of more scalable and interoperable health IT ecosystem to better serve patients. And the things that we do, one of the things that I quickly learned on taking this job was that, you as an agency are all about your authorities. Your authorities define what you can do. Contrary to popular belief, we can't just do anything. I often get, well, why can't you just do this? And it's like, well, because there is no law that says that I can do that. And unless a law says I can do that, I can't do that, right? That's a good thing about our democracy. So the things that ONC is allowed to do and is authorized to do derive mostly from two big laws. One was the HITECH Act, passed in 2009, which was the beginning of the Meaningful Use Program, right? $35 billion in federal investment into the supply chain, essentially, to get provider organizations to adopt electronic health records. ONC's role in that was that we were given the authority to certify electronic health record systems that those providers then could use federal dollars to help purchase. That certification program continues today, to the point that now 97% of hospitals and 80% of ambulatory physicians across the country are using ONC certified electronic health record systems. And certification process continues. Every couple of years, through regulation, we add more and more requirements because we have to keep pace with technology. We have to keep pace with the standards of care. We have to keep pace with people's expectations of establishing that kind of floor of capability across the country. And, I would argue in many ways, that's one of the things, there are a few things, but one of the set of few things that gives our healthcare delivery system across a very, very heterogeneous and large and fragmented and geographically large country, it's one of the things that gives our countries any semblance of systemness. Because otherwise our healthcare system isn't really a system, right? It's very, very fragmented by state and, you got national payers and local payers and national organizations and local organizations and state jurisdictions and, all of that stuff that fragments care. One of the things that does tie it somewhat together is the fact that a certified electronic health record system that's being used in Nome, Alaska, has a lot of the same basic features and functionalities as one being used in Sarasota, Florida. And you can get a core set of information and core functionality out of each of those systems that you can kind of rely on. I mean, it's not perfect. I'm not pretending that it's perfect, but there is a base there that everyone can count on, which is a real value, I would argue, to the healthcare system overall and to the American public overall. So that's one set of authorities which are really big. The other comes from the 21st Century Cures Act, which was passed in December of 2016. And that directed ONC to do a few things, and I'll dive into this in greater detail. One was related to standards. It explicitly directed ONC to establish a set of standards for interoperability using modern internet approaches, namely APIs, application programming interfaces. as well as establishing standards for essentially a minimum data set that we call the U.S. Core Data for Interoperability, the US CDI. That was explicitly in the 24th Century Cures Act directed ONC to do that. Second thing is a set of policies related to what's called information blocking, where we were specifically directed to establish a set of policies related to what the statute specifically prohibited was what they called interference with the sharing of information among authorized parties. And namely, that meant that provider organizations, electronic health record vendors, and health information networks, like iHi, for example, would be a health information networks. There are many others, specifically are prohibited from not making information available to other authorized parties, except for some very good reasons, like they're concerned about security, for example, or it's impossible for them to do it for some technical reason, for example. But in general, it tries to essentially kind of flip the way HIPAA works, or to complement HIPAA, I should say, where HIPAA is more about permission, where it says, well, you are able to share information under these circumstances. Information blocking comes along and says, well, if you're actually able to, an applicable law, whether it's federal, state, local law allows you to, then you actually have an obligation to. And actually the duty is on you to explain why you're not sharing information rather than justifying why you are sharing information. So it is kind of a flip in paradigm. And then finally, TEFCA, Trust Exchange Framework and Common Agreement, nationwide network interoperability. I'll dive into each of these a little bit more, but just wanted to give you an overall picture of the different sort of levers we have available to us. The other thing, just for your awareness, is we were also, because I know here in this community, you deal with lots of different federal agencies, not just ONC. You deal with CMS, obviously, but you also have, a very big research establishment here. So you're dealing with FDA, NIH, CDC, all of our agency partners. In, when was this? July 2022, Secretary Becerra put into a place a policy that directed that all of those HHS agencies base all of their funding, their policies, their data activities on ONC approved standards. So that starts to get more alignment, so that you as a researcher, for example, aren't feeling like, God, you have to do it one way for FDA and one way for CMS and another way for ONC and another way for CDC, and it's killing me. This basically says that all of those agencies are required to start with ONC approved standards and then build from there. And the idea is that that's what the healthcare delivery system is already required to do. CMS and ONC are already requiring that the EHRs and the providers who are using these EHRs do things according to a set of standards. And so we as the federal government ought to be, basically eating our own dog food. We ought to be living and doing what we want the market to do, and living by the standards that we want the market to, to adopt as well. So that's just, really for your awareness that that's going on and, and well underway in the department as well. So that's, kind of one view of the world, which is, what are your authorities? What are the regulations? Blah, blah, blah. The other way that you can think about it, and I like to think of this as a little bit more of a narrative of what's the journey that we're on here, and how do we want to think about that? And how do those policies actually help to enforce that? And I've kind of put it into 4 categories. One is continuing to build the digital foundation. So we have, through the meaningful use programs and others, we have, done what I would argue, I think we're going to, like 10 years from now, we're going to look back and say, that was a remarkable achievement to take an industry that is arguably the biggest and most complex sector of the biggest and most complex economy that the world has ever seen, and take that in a short 10 years from being paper-based to one that is more or less digitally native in many ways, at least a very big core part of it, which is hospitals and ambulatory physician offices, right? That's a pretty remarkable achievement in a very small, period of time. And so what that's done now, I think, has made us, put us in a position where we can start acting as digital natives. Like, why are we doing prior auth the ways that we do it, which is all based on paper-based approaches? Why do we do public health reporting on ways that are basically assuming that people are taking pieces of paper and sending them to other places, right? Why aren't we rethinking all of that? So that all of that's underway, and we're helping to motivate a bunch of that. We certainly have other parts of the healthcare ecosystem that we know didn't get the benefits of those dollars, and where they are not digital natives by any means. Behavioral health, big example. LTPAC, right, long-term post-acute care didn't get the benefit of those dollars. So we are doing what we can within the department to say, all right, how do we fill in those gaps? Every year we ask the Congress for more money to be able to provide incentives and other kinds of dollars to help support those parts of the care continuum. And in the absence of that, I mean, we'll keep trying to get those dollars, but in the absence of that, we're still trying to pull levers to say, how do we get more and more of those resources available so that those organizations can invest in technology to be able to integrate with the rest of the more digital healthcare system that we have now. Second is, how do you make interoperability easier? So the first is, how do I give each of you a phone? The second is, how do I connect you up? How do I make it easier for you to connect with each other? We'll talk about TEFCA and a little bit about APIs. And then the third is, how do we promote it? As we know, just because you build it doesn't mean they will come. And that's a little bit of that information blocking regulations that that the Congress put into place in 2016, where their observation, I think, as expressed through the policy, is, boy, we've invested a lot in these electronic health record systems, and they're interoperable, but people still aren't sharing information. So the problem must be behavioral. It must actually be that the humans are not wanting to share information. It's not that they can't share the information. And so that's where the information blocking rules came around and said, well, we have a way to solve that problem. We're going to require that you share that information, right? That's one way of doing it. And then finally, how do you ensure the responsible use of information? So you've got the information digital and now it's flowing. How do you make sure that there's some guardrails on the other end? So we're doing a bunch of work in what we call health equity by design, but also in AI. And I'll dive a little bit more into AI. I'm happy in Q&A to talk a little bit about health equity as well, because we are doing a lot of stuff there, and there's a lot of overlap in our policies related to AI and health equity as well. But just to flag that for you as a big area of focus for us as well. All right, so let's dive into some of these topics. First, data. So this minimum data set, this idea of the minimum data set, that's now established as what we call the US CDI, the US Core Data for Interoperability. It's required to be supported by electronic health record vendors available to, as I said, I'm going to keep repeating this, 97% of hospitals and 80% of physician offices, right? Large part of the ecosystem has EHR systems that's required to support these data elements. Now, ONC doesn't have the authority to tell the providers that you're required to fill out all those fields. Right? That's where our partners like CMS come in, where CMS comes in and says, well, if you're participating in certain payment programs, you're actually required to fill out those fields and make them available. So that's where we work in partnership with our agency partners. But the point is that the data set is identified and it's available on the technology systems to be used. This is a snapshot of the data classes and the data elements that are in what's called US CDI version 3. Which is now, and this is all available on our website, and the slides are available also for everyone's interest if you want those. But these are the data elements that are in here. Every year we add incrementally more data elements in a collaborative process. So we take input from our federal agency partners, we take input from industry, we have a public website that we call On Deck, so you can go in and you can see what have been the recommendations of every organization, the American Hospital Association, Mass General Brigham, and you can go through, you can look at all the recommendations, and then you can see the disposition of them. Because what we do is we take all those recommendations every year, and then we put them through a set of criteria, like how mature is the data standard that they're proposing? Because if it's really doesn't have any adoption and any testing in the market, it's like, well, we don't want to put that in regulation because that's not, not ready for prime time yet. How important is it to industry? How important is it from a public policy perspective? We go through a set of criteria like that, and then we say, all right, here's the next set of data elements that we're going to add to the US CDI. So it's kind of a rising floor. We try to do that in a judicious manner because we can't do too many at once. Because then all of you as provider organizations, so we're in provider organizations, would kind of choke and rebel, understandably. And of course, the vendors can't support that either. So that's why we try to be, sort of incremental and judicious every year. But we also have additional data needs that come to us from our industry and our agency partners. And so we launched a program when I came in that we call now US CDI Plus. And that's actually just like taken off now. And the idea of US CDI Plus is to say, well, the US CDI is, it's kind of the 80-20 rule, right? It's in every single electronic health record system. So you want to be judicious about what you put in there. But we also recognize that there are additional data needs for specific use cases like public health, like cancer care, for example, and like these other, like other areas that actually have more data elements and more data needs on top of that. So the idea of USCDI Plus is to say, how do we build a more advanced data set, let's say, for a particular use case, but importantly, it starts with the USCDI. So you don't have, you know, an NIH researcher and a public health professional, epidemiologist, the CDC, saying, we're gonna represent medications differently. It's like, no, that's all in the USCDI. You should represent medications the same, represent procedures the same, represent patient demographics the same. Start with that as your starting point. Now let's talk about the additional data elements you need on top of that. And we go through a similar process with them, but a much more focused way to say which of those elements are mature, which of them are important from a clinician perspective, let's say for cancer care. And then we go through that process and then add incrementally to those. And then we use those as a part of like voluntary certification, for example, for cancer centers who are just cancer centers. And they're like, well, you know, we want those. That doesn't mean all Epic customers want them, but MD Anderson wants them for sure. Moffitt wants them for sure. So that's how we work a little bit in, you know, sort of a little bit this agile mode to say, how do you meet those needs of the very specific advanced users in particular areas, but also maintain this floor that everyone can, you know, easily digest. So as I said, this is actually, we weren't sure how much uptake we would get on this, and it's actually been remarkably, you know, sort of powerful and popular. We're almost victims of our success now because it's taken us over. But you know, we've got public health data sets now that we're working on with CDC and jurisdictions to say, how do we get something that could be more like a nationwide public health data model? Which I think for those of you in public health, you know that we don't have a nationwide public health data model, which I think is part of our problem from a public health perspective. But this is getting us to a place that says, how do we do that? And again, all this stuff is available on our website. So you can go and you can see where we are on the USCDI Plus for public health if you have an interest in that and participate. We'd love you to engage and provide your input into that. We also just launched with SAMHSA a USCDI Plus for behavioral health data set that we're doing with a $20 million grant that SAMHSA is issuing. And, you know, $20 million, not big money in our healthcare system. But if we can get, you know, some work done to establish an advanced set of data elements, as well as working with a set of behavioral health providers to pilot those and adopt them, that'll get us on the path to, you know, to a better way of being able to represent important behavioral health needs. With HRSA, we launched for those who are familiar with federally qualified health center reporting, they are required to submit annually what are called UDS reports, which is, you know, sort of a reporting on their activities. We've worked with SAMHSA to fire enable all of that and to add additional data elements that we call USCDI Plus for UDS reporting. They call it the UDI Plus. In many ways, this has actually been the biggest success so far of the USCDI Plus program because it's in production. We got a number of vendors, EHR vendors, to voluntarily agree to support FHIR-based reporting from their systems of these additional data elements, and that went into production on January 1st. And we built a FHIR server for HRSA that they now use to get those reports, right? So pretty exciting. And you've got federally qualified health centers who are the ones at the leading edge doing that reporting. We also, with CMS, are building the quality data roadmap for them as they think about their future quality data needs and how do you FHIR enable all of that and how do you make that, again, tied to the USCDI Plus. And then finally, big effort with the White House Cancer Moonshot team and CMS with the CMMI model program, the enhanced oncology model for those who are familiar with that, where we've got a group of electronic health record vendors plus provider organizations plus federal agencies who have all agreed on building the cancer data set model, starting with M-Code and the USCDI to start to support additional data elements that'll be made available in September of this year to support that first group of provider organizations who are participating in the CMMI enhanced oncology model. So again, all of it tied to the USCDI, but those additional data elements to support their reporting starting in September. So a lot of exciting stuff happening there in the USCDI that I think will continue and hopefully help to serve people's needs. Let's jump now to FHIR and FHIR APIs. Who doesn't know what a FHIR API is? A few. I think there's more of you, but that's okay. So what's FHIR? I mean, just in a nutshell, I'm not going to go through the technical details, and Sean could do a better job than I could anyway. The way to think about it is think about, all of the apps you have on your phone. You absolutely know what a RESTful API is. You just don't know that's what you're doing. Every time you download an app and then put it in your username and credentials, and all of a sudden you have interoperability with, TikTok or, Amazon or, whatever is your app of choice. That is a RESTful API operating in the background to give you fast and easy interoperability in a way that is convenient to you and that you're able to, sort of customize according to your own preferences. That's basically what a Fire API is. It's saying that's how interoperability should work in healthcare. Why do we have that for Uber Eats, but we don't have it for healthcare, right? That's the direction of, of Fire APIs. ONC started requiring that EHR vendors have Fire APIs in their electronic health record products for patients to be able to access their own information and for others, like provider to provider, for example, for care continuity, or provider payer, or provider public health. All of those are requirements now in ONC regulations that EHR vendors were required to have in place by the end of 2022. So it's now, well over a year that they were required to have that in place. That then set us on a path where CMS, our partners, started to say, hey, we're going to take that and triple down on it. So we are going to require that providers who participate in certain payment programs make sure that they have that version of the electronic health record by a certain date, which was 9 months later. And CMS has actually made available its own Fire APIs for its own data. So the DPC pilot, I'll just point to in a second, because we'll come back to this. That's the data at the point of care pilot. That is the ability for a provider, any provider who participates in Medicare, to be able to get access through a Fire API to all of the fee-for-service claims data on their patients, not just the claims that they submitted, but all of the fee-for-service claims data that Medicare has on that patient. And that obviously is really important from care continuity, population health, right? It gives that provider the opportunity to say, I want the breadth of claims and the depth of the clinical information that I have available. It's fantastic, right? Medicare just kind of silently rolled that out, and that's now a Fire API that's available for providers. And then in regulation, they are now requiring, starting in January of this year, they finalized the rule that requires the commercial payers basically do a number of the same things. Commercial payers have been required to make available a member-facing Fire API, but they are also now required to make available a payer-provider API, or a provider access API, as they call it, which is the same thing. So commercial payer that's regulated by CMS and is required to make available a standard Fire API for a provider to get all of the claims data on their patients. Again, all of the claims data on their patients so that they can better serve their patients with a better understanding of, of all the encounters that the patient has had. And then there's a payer-to-payer API requirement as well. So a payer, with your permission as a patient, can share information in the event that you change the health insurers, which happens something like 30% of the time per year for people. When you change your job, often you change your health insurance. This is the opportunity for you to say to your old health insurer, I would like you to send all that claims data to the new health insurer so that they actually have a better perspective on what's been happening to me as a patient. And that's an opt-in, by the way. That doesn't happen unless you ask for that permission, unless you give that permission. And then finally, the last thing I'll point to is the Part D, which is prior auth. CMS has put into regulation the requirement that payers support an electronic approach to prior auth. We have work to do on the provider side, but that's one part of the puzzle, right? That's a really important step and a huge pain point for everyone. Prior auth is the thing that everyone hates, literally, but somehow we haven't been able to get to solve it. Hopefully that's a pathway to do it. The last thing I'll just point to is that with CDC, we are also working now to say, how do we enable Fire APIs to help CDC leapfrog some of the technical issues that we've had with sort of creaky public health infrastructure, to say there are some use cases that we can leapfrog that older technology and move right to Fire-based APIs. So for example, for situational awareness, just the basic stuff that people were filling out in spreadsheets for the pandemic, things like how many hospital beds are available, how many providers are available, how many ventilators do you have, right? Everyone remembers having to report that. That was all manual through spreadsheets. We can have relatively simple Fire APIs support that kind of information. And similarly, immunization registry access through a simple Fire API as well. Those are things that we're working on with the CDC. So that's, sort of Fire APIs to allow access to that information. How does some of that come together? as we think about, these APIs and interoperability in general? Well, here in Indiana, you're very familiar with, with networks. Obviously, all the work that John and, NIHI does has given, Indiana a great capability that already exists here, unlike almost every other state in the country. And, but in 21st Century Cures Act, the direction that the Congress gave to ONC was establish a model to connect up all of these networks, a network of networks model. So to say, how do we have an ability for iHi to be able to connect up to any other network without John having to go and build point-to-point interfaces to every one of those networks, right? Which is kind of how it works today. I mean, there are some nationwide networks. They themselves aren't perfect. They don't connect up as nearly as well as we'd like them to. And there are gaps, as I'll describe. So the direction from the 21st Century Cures Act was for ONC to establish some kind of model, both a governance and a technical approach, to get that network-to-network interoperability. For those who aren't familiar with this, I think of it, the other analogy I like to use is think about the way cell phones work today. We have multiple private cell phone networks around the world. But if you just take the US, for example, you've got AT&T and Verizon and T-Mobile and Sprint, and some of those are consolidating, but you've got these multiple private sector networks. Yet all of us think of the cell phone network as being a single network, right? We never worry that, oh, I'm on an AT&T phone, Sean is on a Verizon phone. If I want to talk to Sean, I better buy a Verizon phone, right? I mean, it almost seems silly that we would think about that. Yet those are individual networks. And there's been a lot of work done by the industry, by the federal government on the back end to connect those networks up seamlessly so that our user experience is as a single network, even though we just choose which network meets our needs, right? What's the best price? What has the best phones? What's best in my house? Maddeningly, my cell phone doesn't work in my house. So all those things, right? That all of us choose which network we want, but we don't worry about whether it's going to connect to the other networks. That was what the Congress directed ONC to do. Is basically to say, that's how that should work here. If I connect to iHi, I shouldn't worry about whether I'm connected to anyone else. Or if I'm connected to another network, I shouldn't worry about whether I'll be able to get information or send information to iHi. I ought to just be able to do that and not have to worry about it. So that was the direction. It's a little more complicated. I'm gonna quickly sort of skip through the slide just to give you a sense of sort of the story of how the industry has gotten us to the place where we are today. But if you think about just the overlay of the adoption of electronic health records, as I described during the meaningful use process, all of that, right? Pretty rapid adoption of electronic health records. And then the question was, well, how do they all get connected up? There were a number of sort of signature points, I would argue, along the way that helped to motivate some of what we see today. One was there was a really now kind of pivotal article written by Ken Mandel and Zach Kahane, who are both physicians at Boston Children's Hospital, who wrote this article in 2009, amazingly, that started to say, you know what, EHRs should be like iPhones. Why aren't electronic health records like an iPhone, where I just have the apps that I want? So I'm not tied to what Epic develops. I'm not tied to what Cerner or Oracle develops. I ought to be able to use that as my base platform, but then just be able to get a whole bunch of apps like I do on my iPhone. Interestingly, I mean, they were saying this in 2009. When did the iPhone come out? Like 2007, right? 2008. So in some ways they were ahead of their time. I would argue, yeah, it was probably pretty early. We didn't even know what the iPhone was then. The iPhone hadn't even figured out what the iPhone was. So, pretty big leap to say that EHR should be like the iPhone when the iPhone wasn't even the iPhone. But pretty forward thinking, I think, and actually led to ONC's giving a grant of $15 million to what became called the SMART program at Boston Children's Hospital, which led to the development of FHIR and led to FHIR APIs that we see today. So, pretty interesting, kind of background and story there. There was also in 2014 a group of like Nobel laureates and scientific advisors that are called the Jason advisors that advise the federal government in kind of a weird secretive process, but they advise the federal government on key technology issues, usually in defense. Actually in national security matters, but they did issue a report on healthcare interoperability. And one of the things that they said in 2014 was this whole interoperability thing has got to move to APIs. Like the whole world is doing interoperability and APIs, and yet you in healthcare are stuck in these older standards that were developed literally in the 1990s, and you need to move. So ONC at the time, led by Karen DeSalvo, Farzam Al-Shari, then Karen DeSalvo, kind of took that and from that developed a set of recommendations through a couple of task forces. I was on one of them that then turned into the FHIR API requirements that we see in regulation today. But it kind of started with that Jason Task Force report that led to the founding of what was called the Argonaut Project that brought together Epic and Cerner and Microsoft and Google and a number of companies to say, how would we actually turn these FHIR API, this idea of APIs, into something that is real and that could be implemented? One of the amazing things that happened coming out of that Argonaut project is not that it turned into federal regulation, because it did ultimately. ONC kind of picked up the work of the Argonaut project and said, hey, we'll take that implementation guide and now make it a requirement in regulation so that all the HR vendors support it. But a really interesting public-private dynamic at that time was that it actually wasn't the ONC regulation that drove the market, it was Apple. So Apple was also a part of the Argonaut project. They were developing the Apple Health Record. And as a part of the Argonaut project, when we had developed that implementation guide, and we finalized an implementation guide, Apple was the first one who said, we are going to make the Argonaut project implementation guide based on open industry standards. We're going to bake that into our operating system, into iOS, and make it available to all iPhone users. And then they started working with hospitals to connect up their systems using these open industry standards. That was the single biggest driver, I would argue, of FHIR in the US, and is still a huge driver of FHIR adoption in the US. And then, of course, ONC regulations came along, CMS regulations, as I described, but that was a real signature moment when Apple picked that up and just took it and ran with it. You had Ken Mandel and Zach Kahani at it again with data networks. I can touch on that in a second. And then I already described the 21st Century Cures Act that came along and said, you really need to think about this TEFCA thing, this network of networks things, because we've got a lot of networks, some of them working, some of them not working, but they just need to be connected. We need to be commoditizing more of the stuff, and we need to be have it be national scale. Because we need to be, have greater consistency across the country in that. And then finally, the rule that we published, which implemented all of that. So I'll touch on some of these things, but just wanted to give you a sense of, starting from EHRs, starting with this idea that, hey, maybe there's a different way to think about interoperability with APIs, then that starts to get instantiated in regulation. People start to think a little bit more creatively about networks and what are networks and what do networks do and how should they be formed. And then that kind of has led us to where we are today. So let me talk about as we think about this interoperability landscape that we're in. You've got a number of clinical sources out there, right? A lot of EHR vendors, as we said, covers 97% of hospitals, 80% of physician offices, all of them kind of doing their thing, some of them connected, some of them not connected. And then you do have a number of networks. You've got state regional HIEs like iHi, like CRISP, like a number of them in New York under the NICE umbrella, a number of them. And then you've got a number of nationwide health information networks as well. With connections across all of them, for sure. None of it perfect, all of it, sort of a little bit brittle, but definitely getting better and better. But still some gaps there. And then finally, you've got a whole bunch of stuff which is like point-to-point interfaces that all of us are familiar with and that we kind of maintain. Whether it's increasingly FHIR APIs, but you've got QRDA reporting for quality reporting. You've got the tried and true HL7 V2 reporting that were the core of iHi when we built when we were founding that way back when. Public health reporting. All of that, and then of course, and I talked a little bit about what CMS is already doing with their APIs. Right, so a complex landscape with lots of different ways of thinking about interoperability. As we start to think about networks, you start to say, well, how do they come together? What kind of makes sense? And I'm going to skip over some of these slides, but the bottom line of the next set of slides are that folks started to sort of think about, we in 2014, ONC had a nationwide program that was roughly, it turned into about $800 million, giving each state, Indiana included, each state a certain amount of money to establish a state HIE within the geography. And the idea was that every state would have an HIE and that those would all get connected up together. And what we found was that state isn't necessarily the right boundary to define an HIE, that in some places like Indiana, it makes a lot of sense because there's already a lot of momentum. There's already a fabulous organization here doing that. They're doing it. There's a lot of buy-in in the Indiana market and the Indiana community for that. But in other states, like my home state of Massachusetts, there really wasn't that kind of appetite, and still isn't. So you'd had a lot of variation, and a lot of those HIEs that were founded ended up not surviving. There are a few who did survive. Some of them predated, all of that work. And then you had a lot of thinking after that that sort of said, maybe we thought about that the wrong way. Maybe we actually ought to be thinking of networks that already just form on their own and connect those up. Kind of like AT&T and Verizon and T-Mobile, right? No one told T-Mobile, you need to create a cell phone business, but they did. They created the cell phone business on their own. And then you have a governance process that sort of says, all right, well, now you're a cell phone business. Now we connect you up with all these others, right? But no one tells them they have to form a network business. No one tells them you can only operate in these states. No one tells them they basically just sort of work on where they want to work. They work with state governments to provide those services in those states, and then they connect up. So that's kind of the idea of this idea of federated networks that are more bottom up. And there's a lot of work from Zach Kahani and Ken Mandel and others who started looking at this, as well as some federal advisory committees who started saying the same thing, which was networks ought to form from the bottom up, and they shouldn't be dictated from the top down, because the minute you dictate something from the top down is the minute that a lot of it just doesn't work, or people just rebel because they're like, well, I have a better model, and now you're not allowing me to have that better model. So let me jump ahead to some of these slides. Okay, let's talk about the gaps, just to give you a sense of, so why TEFCA? Right, with all of that stuff, and and a number of people, John included, sometimes ask, why TEFCA? Well, our answer to why TEFCA is that as much fantastic progress that's been made in the market, and I believe strongly that the market actually doesn't get enough credit for the amount of interoperability that we do have. Not only activities like like iHigh and CRISP in Maryland and in Delaware and other places where there are very, very well performing state level HIEs that are performing a tremendous amount of value added services. But these nationwide networks, for example, do a lot of interoperability that goes unrecognized. But there are limits to what the private sector can accomplish on its own, I would argue, in part because the federal government plays such a large role in healthcare. If you think about Medicare and Medicaid and VA and DOD, you start to add all of those things up and you realize, oh, okay, the federal government's actually a big player here. And actually, if they're not participating in that, that ends up becoming a boat anchor on everything else. And there are certain issues that require policy intervention or policy assistance that the private sector can't tackle on its own. So how do we think about those? So some are like public health. And public health is a great example. No way the private sector can figure out how to get all these jurisdictions across the country to better interoperate, both with each other as well as with the market. There's that's just too hard. It's all split up jurisdiction by jurisdiction. Yet the federal government, working with CDC and partners, can play a role in trying to convene those public health organizations, trying to leverage the policies and the funding that we have to say we can get greater alignment around that stuff and have it be better for everyone if we all, if we think about that in a more, sort of thoughtful way. Less well-resourced providers. How do we fill in the gaps of what the market has left behind? Something like 20 to 30% of hospitals across the country are not connected to any of the nationwide networks, probably because they're less well-resourced. They probably have some vendors that aren't as capable. They're probably on older versions of the software, so their vendor may have a product that is capable of connecting, but they're on an older version because they can't afford it. Right, so all of those issues, the market has left them behind in a way, and the market doesn't have a great way of solving that. So that's another reason for saying, how does the federal government participate here to try to address that part of the ecosystem? Then finally, I'll just point to payers. Payers have been left out completely of these interoperability networks. And that's because of the market. That's because payers and providers are fighting all the time. I don't need to tell any of you that. And whether you're a payer or provider, you no doubt agree with that. And in the market, in these nationwide networks right now that have been largely provider driven, they've actually closed out payers for the most part. We, from a TEFCA perspective, have said that can't go forward like that. In the interest of the American public, payers and providers have to have better interoperability than we have today. It's a cost and a tax on our entire system to not have that information flowing, and when it is flowing, to have it be done in the most expensive ways possible, which is kind of how it happens today. So those are all things that we want to be able to address. Now, I know I'm getting short on time, so let me just talk a little bit about where we are with TEFCA and give you a sense of that. So we have a number of exchange purposes that are allowable under TEFCA. We went live with TEFCA December 12th, 2023. Secretary Becerra making the announcement, large number of people in the audience. There are 7 what are known as QHINs, Qualified Health Information Networks, that are now live. Some of them you may recognize. Epic, eHealth Exchange is one that iHi is a member of, for example. So a number of these networks, together these networks have a pretty big footprint across the market. So we're very hopeful that by connecting these up, they will get their participants to join, and then we'll have that better ability to connect with each other. And there are more QHINs in the queue. So you can think of each of these as like the AT&T and Verizons of the world, if you think of the cell phone analogy. And there are more who are in the application process, some pretty big ones as well. So we're pretty excited because we didn't have the ability to offer funding or anything like that. The last thing I just wanted to mention was that we now are supporting in TEFCA FHIR-based exchange. So that went live in 2023. And obviously adoption takes a while, right? Like with every network, you start off slow and then you start to build up, and that's what's happening in TEFCA. But we also now have the ability to have FHIR-based exchange in TEFCA. So one of the challenges I think that we have as an industry is that it's really hard for these FHIR APIs to be able to scale. And I'm worried that they will actually fail unless we have something like TEFCA to be able to help them with, with scalability. And what do I mean by that? Well, just to give you a very concrete example, if I'm a payer and a provider and you want to be able to exchange information, you want to be able to use it using these modern mechanisms, which is what payers mostly want to do now because they were left out of the previous world of network interoperability. So they're kind of saying, well, let me jump to the new world now, especially because CMS is now requiring them to. I still have to do a couple things, right? I still have to negotiate like a data use agreement. And I still have to go through an onboarding process with you and build the technical interface. And then I have to, test it. And I have to go through a security thing and all of that. And if I have to do that, if a payer has to do that with every provider and a provider has to do that with every payer, then, right, that's just an enormous amount of work. And it hasn't really helped us solve the problem. TEFCA can get rid of a whole bunch of that stuff. Not all of it, but a whole bunch of it, because everyone signs the same data use agreement, for example. It's basically iHi scaled to the national level in that kind of sense. So that's that's the hope and where we are. If we think about where we are from the priorities, and I'll just do 2 more slides and I'm going to stop. Is our priorities for this year are to get our governance fully in place. We're in like a transitional governance right now as we work with the different qualified health networks. We're having a 2-day in-person meeting today. First day is today. I can't be there because I'm here. Tomorrow I'll be there, but that's where all of the networks are together and we're just banging through a whole bunch of these policy things to make those decisions to get it in place. So governance is really important and trust is really important. Payer-provider exchange purpose in production this year. Public health exchange purpose in production this year. And then finally, individual access with the FHIR APIs in production this year. I'll give you one last snapshot of this, which is here. I'm just going to skip over these slides for a second, but just to give you a sense of, people talk about the hardest thing being public health when we started, and there was a sense that, well, that's all great, Mickey, but public health is going to be a problem. And actually, public health is racing out ahead of everyone else. This is a slide that shows the organizations that have already stepped forward, public health agencies, to commit to TEFCA enablement. So we've got on the top left there, you see the pilot states, which are the ones who have said this summer, we intend to go live with TEFCA Exchange. And then we've got the queue in the deep dives of the organizations who, once they saw the first ones, came and said, we want to be a part of that. Like, why aren't we a part of that? So we actually literally are having to put them in the queue because we don't have enough bandwidth to help address, sort of their needs. CDC has got $200 million in implementation support for public health agencies to help them adopt TEFCA. And I've got a whole ONC team that's also working in partnership with the CDC to help public health agencies. If there's anyone here from public health and you want to be able to talk about this, please contact me. We'd love to talk about this. So just that hopefully just gives you a snapshot that this is actually real. And we're actually making progress in what's arguably the toughest part of the ecosystem, which is the public health infrastructure, and helping them, sort of move forward and be able to have modern network interoperability in a way that they haven't had before. So I could also talk about AI. I'm happy to talk about AI in the Q&A, but I'd much prefer to stop and get your questions, see what you're interested in. And, thank you very much for your engagement, and look forward to the discussion.
Open it up to people's questions.
Hi,
Hi.
Marjorie Rollins, and I'm the
Yep.
Executive Director for Health Data Standards, and we lead and manage Loink and Yukon. Thanks for a really great presentation. My question is, we know that our infrastructure isn't where it needs to be completely for full-throated interoperability. But the question I pose to you is, what if it is, right? What if TEFCA, APIs, data standards, all working, together, coordinated, and data is flowing the way that we want it to? What's next for ONC and as it relates to data? What's next for you?
What's next for ONC? Oh, okay. Yeah, that's a great question. Oh.
Data in general.
Yeah, well, I would love to put myself out of a job. That would be, fantastic to me. When interoperability has succeeded is when people stop thinking about interoperability. In the same way that I don't think about what standard my phone uses, and again, like whether I need to buy AT&T, Verizon, right? The fact that I don't think about that is a success of the industry. And I would argue in interoperability, that will be our success when I don't have to face a provider who says, why is the system not working? Why am I not able to, why am I still faxing and receiving faxes? So, but in some ways, I'm not sure that we're ever going to be done. Well, actually, I should say it the other way. I am sure we're never going to be done because there's always more data that people want to exchange. And what we're talking about exchanges are just the things that are made available in these standards-based ways, because that's what I can count on. That sets the explanation, the expectation that, okay, I know I can get a CCD or a FHIR API with US CDI, but it's not going to be very long before people are going to be like, well, wait a minute, you don't have genetic information in there? How do you call this interoperability without having genetic information in there, without it being connected to the phenotypic information, and and then the value-added services, without being able to have a longitudinal view of the patient rather than these kind of just episodic sorts of things that we get from all of these. So I think that there's always going to be more work to do in interoperability to make it better and better and better. But as I said, I think our success will be if we have as a baseline that base interoperability is no longer a question, that we're not faxing anymore, like the experience that I just had with my mother who broke her hip, and they were literally out of an Epic system printing off the discharge information, handing it to me, and asking me to bring it to the rehab hospital so that they could scan it in, even though I knew on the back end they were connected, right? They're connected via Care Quality, I know they are, but no one on the front staff knew it. So we need to get to that point where, where all of that's disappeared. In terms of ONC, we continue to move forward with where the market is. So on Friday, I was named the Chief AI Officer for the Department of Health and Human Services. So now we have a whole expansive set of things that we're doing in AI, which is, the next frontier, right? So we ourselves, as much as I like to put myself out of a job, I don't think I'm going to be put out of a job anytime soon, because there are more and more needs. And I think that there's greater recognition that we need to be working more and more together in these kinds of ways. And ONC in particular is pretty well placed to do that, because that's kind of what we do, is we keep our heads up and say, what do people need from health IT, and how do we make that easier and better?
Hi, Mickey.
Hi.
Thanks for coming back. I'm Bill Tierney. Thanks
Yep.
for
Hi, Bill.
thanks for being.
Another one of the legendary figures who I learned from.
That means old. But I'm interested in how you do it. I mean, you're juggling a lot of balls that are very highly technical, that need to be managed by people with deep knowledge of them. You can't possibly have that level of deep. Now you got AI to be. You got neural networks. And you got all. So. What kind of organizational structure do you have that you can manage all of this? Because you're not doing it all yourself. What's the structure of ONC that allows you to have all these deep technical things, making the right decisions, or at least making decisions and see whether or not they're right?
Yeah.
But how does that happen? I mean, it seems like almost an impossible task to be able to manage all.
Yeah. So a couple of things, I guess, like on the personal front, I am neither a physician nor a computer scientist, which I actually think is perfect for the world that we live in now, because I don't get too down into those weeds. I'm able to sort of, keep above here and say, well, how much do we need to figure out that's important from a policy perspective without getting too tangled up in, in the deep weeds. But more, seriously to your question, ONC is a pretty small but mighty organization. We have 180 people. And we have a budget of $65 million, which I know by any absolute measure is a lot of money. For a federal agency with our responsibilities, it's really not. We were founded in 2004 with $52 million in 2004 dollars. And now here we are with this much more, sort of responsibility with $65 million. We've lost, right? If you count inflation, and we've lost actually probably 50% in real terms. So we have as I said, we have a really good seasoned staff that covers a wide variety of domains. We got technology staff, a policy staff. We lean very heavily on our federal advisory committees. So we have, it's now called the high tech. It used to be the HIT policy committee and the HIT standards committee, where, we had experts like Clem and others who were willing to roll up their sleeves and devote as much time as, we asked of them to help us sort through a lot of these technical and policy issues. So it really is. And then, of course, we do have our federal agency partners. So across the federal agencies, there's a lot of deep expertise as well. So as we get into AI, for example, I do have the luxury of being able to tap into the FDA team, who have been approving software as a medical device, solutions for, they've got 700 that have approved now. So I can dive deep into, and NIST, for example, has deep technical expertise that we can tap into as well. So, but you do need to, be able to figure out, all right, where are those pools of talent? How do we leverage them in the best way possible? And then bring that all together, resurface so you're not drowning in the detail, resurface so that you can actually turn that into policy that's, that's going to be implementable.
Excellent. Well, thank you, Mickey. One more round of applause for Dr. Tripathi.
Great. Thank you.